Hello, welcome to the virtual meeting. Sorry we couldn't meet in person. I'm excited to be here today. I would like to thank the organizers for inviting me to give a talk on triple-negative breast cancer, predictive and prognostic biomarkers for neoadjuvant therapy. I'll review the rationale for neoadjuvant therapy in PCR, predictive versus prognostic biomarkers, and future considerations. So let's first start with neoadjuvant therapy. What are the advantages of neoadjuvant therapy? From a patient perspective, there are three advantages of neoadjuvant therapy. The first is that it could improve the rate of breast conservation therapy. You can shrink the tumor, make it easier for the surgeon to remove the tumor and increase the rate of lumpectomy and breast conservation therapy. The second is that by starting systemic treatment first, potentially you're targeting micrometastatic disease earlier. You're targeting the disease that cannot be seen. You're targeting micrometastatic disease. And the third is because the tumor is still intact, it allows for assessment of tumor response to treatment. From a research perspective, there are also a couple of advantages of neoadjuvant therapy. The primary being that it can help identify predictive and prognostic biomarkers. This many times is a source of confusion. What's a prognostic marker? What's a predictive marker? So let's review predictive versus prognostic biomarkers and what they mean. As you can see in the slide, this is a standard neoadjuvant design. Patient with stage 1 to stage 3 triple-negative breast cancer receiving neoadjuvant therapy. Patient gets biomarker testing, and if the biomarker is present, patient is randomized to standard chemotherapy, say weekly paclitaxel or weekly paclitaxel plus novel therapy. And if the biomarker is absent, the same novel therapy plus weekly paclitaxel or weekly paclitaxel. So if you look at the impact of the biomarker on response to neoadjuvant therapy in general, that would be a prognostic biomarker. So for example, if the biomarker is present and the response rate is higher, both in the novel therapy plus weekly paclitaxel or the weekly paclitaxel arm as compared to the group where the biomarker is absent, that would be a prognostic biomarker. The presence of the biomarker associated with higher response regardless of the type of treatment, or vice versa. Presence of the biomarker could be associated with lower response regardless of the treatment. The second is predictive biomarker. This essentially refers to whether the presence of the biomarker predicts for benefit or lack of benefit from a given therapy. So in this scenario, you would note that if the biomarker is predictive, then there would be higher benefit with novel therapy plus weekly paclitaxel as compared to when the biomarker is absent for that group. But for paclitaxel, in either of the group, whether the biomarker is present or absent, the response rate would be the same. So if you're seeing that scenario, that would suggest that the biomarker is predictive of benefit with the novel therapy. The second advantage of a neoadjuvant trial is that it provides an efficient trial design for assessment of efficacy of novel therapy utilizing PCR or pathological complete response as a surrogate marker for survival. So what is PCR? PCR essentially refers to the absence of invasive tumor at the time of surgery after neoadjuvant therapy. And multiple studies, including a recent meta-analysis, demonstrated that PCR is a strong predictor of event-free survival, particularly for triple-negative breast cancer. Patients who have PCR have a 5-year event-free survival of 90% or higher as compared to 55 to 60% in the residual group as seen in this meta-analysis. So it's a strong prognostic marker and thus could be a surrogate for event-free survival. And this has led to an interest in neoadjuvant therapy. If you look at the timelines for neoadjuvant therapy, the neoadjuvant regimen was first utilized in the 1970s. And essentially at that time, it was preoperative chemotherapy with radiation therapy for locally advanced breast cancer. This then got moved to the it got moved for patients with early breast cancer, where the NSABP trial, NSABP 18 and 27, compared neoadjuvant regimen to adjuvant regimen and demonstrated that essentially the outcomes are the same, but neoadjuvant regimen has the additional advantage of improving breast conservation therapy. And in the 2000s, there were a number of trials looking at targeted therapies, particularly trastuzumab in the neoadjuvant setting, leading up to the Catherine trial, which demonstrated how neoadjuvant therapy could influence the adjuvant study design. And there are a number of trials evaluating novel therapies in this setting. Perhaps the game changer in this space has been immunotherapy. Neoadjuvant immunotherapy, a couple of trials have shown improvement in pathological complete response with the addition of immunotherapy to chemotherapy, both with Pembro as well as with Atezo. And if these agents are approved, they would be a game changer in the field of neoadjuvant therapy and early triple-negative breast cancer in general. Now, while the addition of immunotherapy is associated with an improvement in response rate and potentially event-free survival, these are results from the Keynote 522 trial, where patients who received immunotherapy had a trend towards better event-free survival as compared to the control arm. Obviously, we need additional data and more follow-up to look at the mature event-free survival. The potential downside to immunotherapy is the adverse events. Immunotherapy is associated with IRAEs, or immunotherapy-related adverse events, and some of these adverse events can be irreversible. So on one hand, the addition of immunotherapy to standard chemotherapy can be associated with an improvement in pathological complete response. On the other hand, it's also associated with more adverse events. So how do we choose the optimal regimen for an individual patient? That's where biomarkers come in. Can we utilize biomarkers to optimize the efficacy-toxicity ratio, where the hypothesis being that predictive biomarkers and potentially even prognostic biomarkers can be utilized to optimize the efficacy-toxicity ratio for a patient with localized triple-negative breast cancer. And this biomarker-guided selection could allow for de-escalation of chemo in some patients and escalation in others. So now let's review the biomarkers. If we talk about biomarkers, we can broadly divide them into two categories. The first being biomarkers associated with key genomic drivers and signaling pathway inside the cancer cell. This includes the BRCA, HRD pathway, PI3 kinase AKT pathway, and the apoptosis pathway. The other is biomarker associated with the immune microenvironment, so what's around the tumor, and this includes PD-L1 and TILs. We'll review them one by one. So let's start with BRCA and the HRD pathway. Question: do patients with BRCA mutations respond to neoadjuvant anthracycline versus platinum? This was a question that was addressed in the INFORM trial. Patients with localized breast cancer who had BRCA mutation, germline BRCA mutation, were randomized to receive cisplatin versus anthracycline. The rationale being that cisplatin in previous studies had shown a very high response rate in patients who had germline BRCA. So the idea was, could you replace AC with a platinum? Essentially, the study showed that there was no difference in PCR. Patients who got platinum versus AC, the response rate was pretty much similar. And this is not surprising, because if you look at the DNA damage and repair pathway, anthracyclines are topoisomerase inhibitor. They affect cells which have deficiency in HRD or which have deficiency in DNA repair. So with anthracyclines, you induce DNA repair, and if a cell has deficiency in DNA repair, that would be synergistic, which is very similar to platinum as well, which are also DNA damaging agent. So it's not surprising that there was no difference between a platinum and an anthracycline as far as response to neoadjuvant therapy is concerned in patients who have germline BRCA mutation. The other question is, what if you add platinums to anthracyclines? If you have a standard anthracycline backbone, if you add a platinum, do you observe higher response rate? And this is exactly what was seen in the GAPAR-62 trial, that patients who have germline BRCA mutation had higher response rate with the combination of platinum plus anthracycline. And again, it makes sense based on the mechanism of action of these agents. So how about HRD? We talked about BRCA mutation. Broadly, all of this comes under the homologous recombination deficiency, or HRD, which includes BRCA mutation, but also includes non-BRCA mutations, which can result in HRD, or the so-called BRCA-ness. And this is measured by different assays. One standard assay is the Myriad MyChoice assay, which looks at LOH, TAI, LST. Besides the BRCA mutation, a score is obtained, the cutoff being 33 or 42, depending on different publications, and that is considered to be HRD positive. So in the SWOG trial, the team led by Dr. Priyanka Sharma looked at response to chemotherapy, AC versus and the association with HRD in patients with stage 1 to stage 2 breast cancer. And this was presented at San Antonio Breast Cancer Symposium last year. And essentially what the team demonstrated was that the presence of HRD is a strong prognostic biomarker. Tumors that do not have HRD or DDIR have worse 5-year disease-free survival of 56%, as opposed to tumors that express both, where the 5-year disease-free survival was 80.9%. So it's a strong prognostic biomarker. It also predicts for sensitivity to DNA damaging agents, which is to be expected because it refers to a deficiency in DNA repair. If you have a DNA damaging agent, the cell or the tumor cell would be more susceptible to such an agent. So what have we seen in the neoadjuvant setting? What is the association between HRD and response to chemotherapy? There was a recent pooled analysis led by Melinda Telly and her group, where they looked at the HRD assay, the MyChoice HRD assay, and looked at the response to neoadjuvant platinum by pooling results from 5 different trials, and essentially showed that the presence of HRD is strongly associated with the response to neoadjuvant platinum, with an odds ratio of 12.09, as opposed to tumors that do not have HRD. So again, it appears to be a marker that is associated with response to platinum. How about using this biomarker for selection of therapy? That's where things get complicated. There was a recent study led by Erica Mayer and her group where they compared platinum versus paclitaxel stratified by HRD. The hypothesis being that tumors that have HRD would have higher response to platinum, not so much to Taxol, and thus it could be utilized for selection of therapy. Turns out that there was no difference in PCR between the two groups. In the HRD positive group versus HRD negative group, while the response to platinum was higher in HRD positive versus negative, again, something similar to what was seen previously, if we compare to paclitaxel, there was no difference. The PCR rate was 13% in HRD positive with cisplatin, and it was 14% in the HRD positive with paclitaxel. So HRD is not a biomarker that can be used to select patients who should get platinum. So moving on to signaling pathways, the PI3 kinase AKT pathway. A lot of interest in this pathway for potentially selection of targeted therapies, particularly AKT inhibitor. The Fairlane trial looked at patients who had localized triple-negative breast cancer and randomized them to receive paclitaxel plus placebo versus paclitaxel plus an AKT inhibitor, ipatasertib. The hypothesis being that tumors that have altered PI3 kinase AKT pathway would respond more to paclitaxel plus ipatasertib. Unfortunately, these study results were negative. There was no difference in pathological complete response between the two groups, and this was overall in the study as well as the subgroup that had altered PI3 kinase pathway. There was a slight trend with higher PCR with IPAD assertive 17.9% as opposed to 11.8%, but this was not statistically significant. Potential explanations could be maybe it's not the right biomarker, maybe there's a lot of tumor heterogeneity in the signaling pathways, or maybe it's not the right drug. IPAD assertive is not just sufficient to block this pathway. So additional biomarker work is ongoing to look at these hypotheses. And then finally, the apoptosis pathway. It's a very different concept from HRD or PI3 kinase. Here, the idea is to affect apoptosis in cancer cell. And apoptosis can broadly be divided into intrinsic pathway and extrinsic pathway. For the extrinsic pathway, which is mediated by TNF-alpha, there's interest in using IAP antagonist, example being LCL-161. So there was a neoadjuvant trial which looked at efficacy of LCL-161 plus Taxol versus Taxol alone stratified by the TNF-alpha based signature. So this is the design. About 200 patients were randomized to receive either LCL plus paclitaxel or paclitaxel alone stratified by the TNF-alpha based gene signature. So what did the results show? Essentially, the results demonstrated the predictive value of the gene signature. So let's review this. If you look at the overall PCR in the gene signature positive group, the PCR with LCL plus paclitaxel was 38%, and this was much higher than what was seen in the control group, where it was 17.2%. So 17.2% in the control group. If we look at the gene signature negative group and look at the control group, the PCR was 16.4%. So it highlights that the gene signature is not prognostic. The presence or absence of gene signature does not affect the response to standard paclitaxel chemotherapy. But in terms of the predictive component, you could see that the presence of gene signature is associated with higher PCR when LCL-161 is combined with paclitaxel. The downside with this regimen is the side effect. It was associated with diarrhea, nausea, and perhaps worrisome side effect of pneumonitis. 10% of patients who received the combination therapy had pneumonitis. And this is a scenario that we sometimes see in drug development where you have a nice biomarker, you see responses, but then because of toxicity, the development becomes challenging. Now, finally, moving on to the immune microenvironment. The pivotal Keynote 522 trial looked at the combination of Pembro with carbotaxol AC versus carbotaxol AC without Pembro in patients with localized triple-negative breast cancer. The study was positive. It showed an improvement in PCR with immunotherapy. 64.8% of patients had PCR with Pembro as opposed to 51.2% without Pembro. Looking at PD-L1 positive versus PD-L1 negative subgroup, there was no difference in the response rate based on PD-L1 in terms of the predictive value of PD-L1. So the benefit with Pembro was seen in both PD-L1 positive and negative subgroup. But there appeared to be a prognostic value of PD-L1. The presence of PD-L1 was associated with higher response rate in both Pembro as well as the control group. 68.9%, 54.9% in PD-L1 positive subgroup, as opposed to 45.3 and 30.3 in the PD-L1 negative group. So PD-L1 positivity, at least in this trial, was a prognostic biomarker associated with higher response rate, but was not a predictive biomarker as far as response to immunotherapy is concerned. Similar results were seen with Atezo. Patients who receive Atezo plus chemotherapy, this trial, Impassion 030, looked at ACT or anthracycline taxane backbone without platinum, and very similar to the Keynote 522, demonstrated improvement in pathological complete response with the addition of immunotherapy as opposed to chemotherapy alone. How about TILs? TILs essentially refer to tumor infiltrating lymphocytes, and essentially it's looking at the immune microenvironment. The presence of TILs consistently has been associated with higher response rate. This was probably elegantly first described in the GAPAR-6 trial, where the team demonstrated that the presence of TILs was associated with a much higher response to platinum as opposed to the absence of TILs. This has also been seen in the NeoSTOP trial. As a reminder to the group, NeoSTOP trial was a trial which looked at carboplatin followed by AC versus carboplatin with docetaxel without AC, led by Dr. Priyanka Sharma. And the trial nicely demonstrated that there was no difference in PCR between the two groups, suggesting that you could potentially use a non-anthracycline-based regimen for patients with triple-negative breast cancer. And in that trial, looking at the association between TILs and response rate, patients who had stromal TILs in the tumor with a cutoff of 20% or higher were twice as more likely to have a PCR as opposed to the other group. And this showed a trend towards statistical significance with a p-value of 0.09. A recent analysis looking at the SWOG study also confirmed the prognostic value of TILs. The presence of TILs, of stromal TILs, more than 20%, was associated with improved disease-free survival as compared to the other subgroup. So it's clear that the presence of TILs is associated with better prognosis. And finally, this was also seen in a recent pooled analysis where the authors pooled 5 different studies and looked at the association between TILs and PCR to neoadjuvant therapy, and demonstrated that the presence of stromal TILs is associated with higher response to neoadjuvant therapy. It is something that is associated with better prognosis as well. Which brings in the question, can we use stromal TILs to identify patients who are high likelihood of having PCR, and thus these patients could potentially be considered for treatment de-escalation, particularly stage 1. So you can use this biomarker, which is prognostic, potentially for predictive value as well to de-escalate treatment and thus reduce toxicity for patients with breast cancer. So we reviewed the key genomic drivers, we reviewed the immune microenvironment. We looked at all of these components individually. The challenge is that these pathways are interrelated. The BRCA-HRD pathway is related to the immune microenvironment and vice versa. So while studies look at these components individually, in reality, it's much more complex, which makes it difficult to tease out the predictive component of each of these biomarkers together, as well as in combination for an individual patient. The other challenge is the assay. What assay should be used for HRD? There are different assays, and different studies have used different cutoffs. Similarly for PD-L1, different assays that measure different things. And it just becomes very difficult to interpret the various studies when the assays are not standardized. Besides biomarkers, the other strategy to consider to guide neoadjuvant therapy is this concept of a hybrid model, where you look at initial response to neoadjuvant therapy, and based on the initial response, you can titrate further therapy, de-escalate treatment in patients who have a good response, and escalate treatment in patients who don't have a good response. So the initial response to neoadjuvant therapy can be utilized to optimize the efficacy toxicity ratio. And so example being patient with stage 1 to stage 3 breast cancer gets an abbreviated regimen for 4 cycles. And if the patient has a very nice response, close to a complete response or complete response, goes to surgery. On the other hand, if a patient does not have a complete response, then the presence of residual disease is confirmed and the patient could get additional treatment. So this is response-guided treatment for an individual patient. And I think we are going to see more and more studies that utilize this hybrid model. The other advantage is it's rich in biomarkers. You can obtain blood as well as tissue to really understand the different biomarker component, predictive, prognostic, as well as understand mechanisms of resistance to different therapies. So in conclusion, PCR is a valuable surrogate biomarker for identifying signals and trends in breast cancer therapeutics. PCR is associated with better outcomes than no PCR, but the disease-free survival is not 100% in patients who have PCR, and vice versa. The disease recurrence is not 100% in patients who do not have PCR. TNBC is a heterogeneous disease, and classification of TNBC by HRD, DDIR, and genomics may have prognostic and therapeutic implication, but we need better understanding of the interdependence between the different biomarkers, the cutoffs, and the impact on therapeutic response. Prospective validation is needed before these biomarkers can be incorporated in clinical practice. Currently, we lack level 1 evidence to suggest ACT chemotherapy backbone could be reduced in patients with TNBC. Presence of TILs is associated with good prognosis and higher response to neoadjuvant therapy. So potentially in the future, TLs could be utilized to de-escalate treatment, particularly for stage 1, but this needs validation in clinical trials. Besides baseline biomarkers, studies evaluating initial response to neoadjuvant therapy as a strategy to de-escalate standard chemotherapy in some patients and escalate in others, thus optimizing the efficacy-toxicity ratio in patients with localized triple-negative breast cancer. Thank you for your attention.